Millions of people are now on these drugs. Most of them were never asked the one question that actually matters before starting, not about their weight, not about their diet, about whether this drug is even safe for them in the first place. There are situations where starting is a hard stop, others where the timing alone makes it dangerous, and some that get missed entirely until something goes wrong. Some situations are not gray zones. A personal or family history of medullary thyroid carcinoma, a rare type of thyroid cancer, is one. Pregnancy belongs very close to that category too. Active pancreas inflammation or severe pre-existing delayed stomach emptying belongs in the stop-and-reassess category, not the casual start category. These are situations where the usual risk-benefit calculation no longer works the same way. I'm Dr. Kim. This is not medical advice. Consult your doctor. 3 groups matter here. True hard stops, situations that can become dangerous quickly, and the quieter ones that tend to get missed until they cause a problem. And one of the biggest mistakes is assuming side effects always mean the drug is the problem. Sometimes they are actually revealing that the patient was the wrong fit from the start. First, the true hard stops. A personal history of medullary thyroid carcinoma is a hard contraindication. This rare thyroid cancer, known as MTC, starts in a different type of thyroid cell from the more common thyroid cancers. The same applies to multiple endocrine neoplasia type 2, an inherited condition that raises the risk of certain hormone-related tumors, or a known family history of either. These agents caused C-cell tumors in rodent studies. The relevance to humans remains uncertain, but the signal was serious enough to produce a boxed warning across the approved class. This is not a close call. If either of these diagnoses is in the history, that conversation has to happen before anything else. Pancreatitis is the second major red flag category. Pancreatitis means inflammation of the pancreas, the organ just behind the stomach. These medications carry a pancreatitis warning, and acute pancreatitis has been observed in patients treated with this class. That does not make every prior episode an automatic never again case. But someone with current pancreatitis should not be starting, and a history of recurrent or chronic pancreatitis warrants a careful discussion before prescribing. The practical problem: nausea and abdominal discomfort are common side effects, which means a true pancreatitis signal can look like a routine complaint at first. Abdominal pain that becomes sudden, severe, or radiates to the back should be evaluated promptly, not waited out at home. Pregnancy sits in its own category. These medications are not recommended during pregnancy. For Semaglutide specifically, the label supports stopping at least 2 months before a planned conception, because the drug is not out of the system quickly. For someone who becomes pregnant while on a GLP-1, that is a conversation to have immediately, not at the next routine visit. Now to the situations that can become dangerous quickly. Gastroparesis deserves more than a side effect warning. These drugs slow stomach emptying as part of how they work. In someone who already has gastroparesis, a condition where the stomach empties too slowly, that effect compounds the disorder significantly. In plain terms, food sits in the stomach longer than it should. Severe gastroparesis is listed as not recommended in current Semaglutide and Tirzepatide labeling, which tells you this is more than a routine nausea issue. Undiagnosed gastroparesis is also a common reason these drugs become very hard to tolerate early on. This is particularly relevant in patients with long-standing diabetes, where gastroparesis is more prevalent. Eating disorders and low body weight fall into the same category. Wrong physiology for this drug. Appetite suppression is the feature people want. In someone who is already underweight, or someone with a history of restrictive eating, that feature becomes a liability. A drug that makes eating feel unnecessary can accelerate an already difficult pattern. And this risk is easy to miss because weight management visits often stay focused on body mass index and current intake, while older restrictive patterns never get surfaced unless someone asks directly. Kidney disease is another situation that requires closer oversight. Nausea and vomiting from this class can lead to meaningful dehydration, and in someone whose kidneys are already working at reduced capacity, that becomes a more serious problem more quickly. Acute kidney injury, a sudden drop in kidney function, has been reported in association with severe digestive side effects in this population. Then there are the situations where timing is the problem, not the drug itself. Surgery is one most patients forget to mention because they do not think of a weight loss injection as relevant to an anesthesia conversation. It is relevant. Because stomach emptying is slowed, retained contents carry a risk of aspiration during induction. Aspiration means stomach contents entering the airway during anesthesia. Those at higher aspiration risk may need a different approach, and that needs to be on the preoperative list. The same applies to upper endoscopy, where food still sitting in the stomach can obscure the view and increase procedural risk. Gallbladder disease is quieter but real. Meaningful weight loss is itself a known risk factor for gallstone formation, and current Wegovy labeling includes an explicit warning for acute gallbladder disease. These drugs may also reduce how efficiently the gallbladder contracts and empties bile. Bile that sits longer forms sludge, and sludge becomes stones. It is usually a slow process that goes unnoticed until symptoms begin. Two more situations belong on the monitoring list. Tirzepatide products have one practical issue many people never hear about. Oral contraceptives may be less reliable after starting and after each dose increase. A non-oral method or a barrier method, such as condoms, is the recommendation for the first 4 weeks of treatment and for 4 weeks after each dose increase. Diabetic retinopathy is another concern for anyone with diabetes on one of these medications. Diabetic retinopathy means diabetes-related damage to the small blood vessels in the eye. Rapid blood sugar improvement can temporarily worsen existing retinal damage, a pattern specifically noted in Semaglutide trial data, and current Wegovy labeling continues to carry a related caution. For someone with a pre-existing retinopathy diagnosis, the pace of glucose reduction and how quickly the dose is increased deserves closer coordination with an eye doctor. Here is the mistake many people make with this whole category. They think screening is just a quick formality before the prescription. It is not. Screening is part of the treatment. What happens when this screening does not occur is predictable. Someone starts the drug with an undiagnosed contraindication. The side effects that follow get attributed to the medication class rather than the underlying condition. The real problem gets missed, or identified later than it should have been. The screening conversation has to go beyond weight, appetite, and a hopeful prescription. Pancreatic history, pregnancy plans, kidney and liver function, eating history, surgery timing, contraceptive use, eye disease, and thyroid or endocrine tumor history all belong on that list. The drug does not know your history. Your doctor should. That conversation only happens if someone actually asks the right questions. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.